All right. Well, hello everyone. I'm John Mattox. I'm a trauma surgeon. I'm a USIS grad and a Walter Reed grad, and glad to be back. So thank you, Dr. Worlton. So I want to talk to everyone this morning about trauma systems engagement, what we're doing at USIS, and take a look at Jordan as really an example of what we're trying to do. So the standard military disclaimer: I have no financial disclosures and everything is unclassified. At the end of this talk, I want everyone to be able to understand what is global surgery, why it's important to the DoD, and take a look at what are the pitfalls. What can we do wrong? And instead of helping people, actually hurt things. So what is global surgery? Back in 2015, the Lancet put together this definition. It really distills down to a bunch of people working, a bunch of disciplines working together with the common goal of getting access, equity, and improved outcomes for people who need surgery, specifically those in crisis situations and those who are in underserved areas. What does this operationalize as? Mostly it's direct care. That's the high visibility stuff. Going out and actually providing surgical care for people in underserved areas. There are a lot of actors in this space. There are NGOs, faith-based organizations, governmental organizations, and the military. So that is the most popular way of engaging with global surgery, but there are other avenues as well, including coaching and mentoring from high income to low income areas, educational opportunities, either training in these areas which are underserved or bringing folks to highly served areas to get further training and go back. Systems enhancement, looking not just at the care, but the mechanisms of care, the organizations of care. And then academic partners between institutions and high-income countries, low and middle-income countries, exchanging knowledge and really rising up and bringing up the academic understanding and educational opportunities. So why do we do it? Well, about 5 billion people do not have access to adequate surgical care. Specifically in low and low middle income countries, some places 9 out of 10 people have no access to basic surgical care. Worldwide, that results in about 150 million cases that don't get done. It's a lot of people who could be helped. A lot of people who need surgery and don't get it. So why trauma surgery? Obviously, I'm a trauma surgeon. I'm interested in trauma. I like the trauma system stuff. But why do it? Well, trauma and injury is about 8% of all deaths. And for the age groups of 5 to 29, road traffic injuries are the #1 cause of death. So focusing on trauma and the aftercare after injury can really make a big difference. For me, trauma care is critical care for the injured patient. It's not just the surgery, it's the care afterwards. It's all the components of that care. It's having a good blood bank, it's having good lab services, RT, bringing everyone up. And don't forget nursing. Nursing is critical. If you don't have that bedside skills, those trauma patients won't do well. So if you look at trauma as a focus, it is a specialty, but it also brings up the entire care system that then can translate over to regular critical care of medical patients, acute care surgery, obstetrics, having a good blood bank. And then the DoD and the combatant commanders, obviously they're interested in casualty care, and trauma fits right into that. Before we go into what we're doing or trying to do over at USIS, I want to talk a little bit about what can go wrong. And this is where we really have pitfalls. Follow-up, especially with direct care missions. Going over, performing surgery, we all know it. If you don't want to have a complication, don't do surgery. Well, what do you have in place to handle those complications? Especially with these short-term missions. We go in, do an operation, and then we leave. What happens to that complication if it exceeds the abilities of the location to manage? What happens to that person when the whole team that did that direct care mission all of a sudden disbands when they get back to their home? Who's taking care of them? Unintended consequences. Our goal is to help people to go out, provide care, improve the system. What if what we're doing displaces the care that's there or undermines the trust in the local healthcare system? When we, as a high-income mission, leave, we've done a detriment, and that it's undermined the care that that population has 24 hours a day, 7 days a week, and maybe 49 weeks a year. So the majority of their time. We don't understand the limitations. We don't understand what the impact the environment has. For us, we have big rains. What does that mean? Traffic sucks. Well, in some places that means roads are impassable. It means people can't get to the clinic. And if you are stuck in a small hospital, small clinic managing someone, maybe it's prolonged field care equivalent until you can get them to the higher district hospital. The other thing that is unfortunately a common occurrence is save up a bunch of money, buy wonderful gifts, bring very expensive high-tech stuff, say like a really nice operating table. Well, what happens when that operating table breaks and the systems are not in place to get the repair parts? The knowledge isn't there to repair it, or the power goes out and you can't fix it. Well, where does it end up? Ends up out back by the trash heap. And this is an unfortunate common occurrence, that a lot of money is spent on fancy equipment that doesn't really affect the care. And that money could be spent elsewhere that would be much more effective. So it's not as shiny and nice as getting a picture of handing over an operating table. It's not our home. We coming from high-income countries cannot be more invested in the success of this improvement or this mission than the people who we're going to help. Because as soon as we leave, if we're the most invested people, nothing happens. It has to be driven locally because the local population knows the limitations, they're invested, and they can anticipate some of the unintended consequences if we talk and we listen. And part of this is success. Success takes time. It's not a one and done. You can't go do 2 weeks of surgery and say, oh, it's all fixed, everything's great, because it's not. It takes time, it takes iterative exposure and long-term relationships. And then success. What is success? What are our goals? And how do you measure that? Is success a beautiful picture? Or is success knowing that the port is a deep water port? The stevedores are great and can do ship's husbandry, and we trust the country with our big white ship. That's great. That's a wonderful. We can measure that success. Is it going out and doing a bunch of surgeries? I don't know. We learned that sometimes the pure number of, say, body count doesn't equate success in Vietnam. So what is a success? How do we measure what matters? And then implications for the DoD. We are a high visibility organization. We represent the United States of America. We are ridgelined, skylined, anytime we do anything. So if we don't have some form of mitigation for all of these previous missteps, if something bad happens, we have competitors operating in the same space who would be more than happy to sweep in, fix our complication, and then put up the headline, killed by hospital ship, killed by medical mission. These are things we have to think about. This doesn't mean don't do it. It means be smart. Make sure that you understand where things can go wrong. That being said, let's talk about what we're doing over at USIS. We're not doing direct care. We're doing tactical combat casualty systems engagement. What does that mean? Well, let's start out with a case. 29-year-old staff sergeant deployed overseas, a relatively permissive environment. They're on their way back from the capital city. They fall asleep, drive into the desert or the woods, wreck their car. They're pretty banged up. Looks like they need a surgeon. Well, in a deployed DoD system, We'll send out our medics, we'll stabilize them in the field, we'll fly in a helicopter, move them to a roll 2, they'll get damage control surgery from a surgical team, they'll get US blood, US equipment, plugged right into the US medical evacuation chain, be back in launch stool within 24 hours. That's great. Pretty wonderful. Costs a lot of money. It's a huge logistic footprint. It's a lot of manpower that's dedicated to that. And for those surgeons who are out there, we're there as an insurance policy. We're not there doing lots of care unless we're in a combat or a highly kinetic environment. That's a different animal. But if we're there as an insurance policy, we're going to lose our skills. We're going to sit there, you're going to do sick call, and try not to go crazy. Well, what if there's no DoD presence there? Then we rely purely on the host nation. And that's variable. Is there an EMS system? Are there medics? Are they trained medics? Is there even an ambulance? Do you have to take a cab to the hospital? What's the quality of care? Many places the care on the physician level is very good. Western trained, good quality local training. Maybe the nursing care is not great. Maybe the techs are not great. How safe is the blood supply? These are a lot of questions we don't have the answer to. What does it mean for the DoD? Well, we don't have a big logistic footprint. We don't have to pay as much money. There's no surgical skills decrement. But what does it mean for patient care? What does it mean for operational support? And what does it mean for interoperability? Can we operate in the same space with a common language and common skills? Probably not. Well, at USU, we're looking at the Tactical Combat Casualty Care System project. We're looking to build a center for trauma systems engagement, drawing on the DoD trauma systems experience for the last 20 plus years, looking to pull USU faculty from across the MHS to help staff these missions. We're building global health experience. We're pulling people with global health experience, building a backbench, bringing in students, bringing in residents to come on these trips and learn. We're focusing on academic engagement and systems engagement, not direct health care provision. We're partnering with interested allied medical systems, military medical systems, helping them develop their care capacity and overall improving patient care. So how do we do it? Well, it starts out with the ask and the relationship with our allied partner. Then we'll do a trauma systems evaluation. We've developed a tool that's been used in multiple countries, South America, as well as the Middle East. We're going to form a gap analysis where their problems are, their areas are, where they can get stronger and better. Then work with our partner to develop goals that are unique to them. What are they interested in doing? Because it can't be our goals, it has to be their goals, and we'll help them meet that. Ideally, they're mutually beneficial goals, aligned. Then we'll work on that plan of action. But really, a big key part of this is this ongoing engagement. We have follow-up, engaging with folks. So it's not just handing over a nice 20-page document with a checklist. Here you go, just follow this checklist. Good luck to you. We're actually going back, helping them navigate the improvement process, engaging with their plan, engaging with the challenges that they run into, and coaching them as they go through this. Again, the ideal end state is that it's fully interoperable, that the care is equivalent, which means we don't necessarily have to put in a full medical footprint, but we can go and rely on our partners, trusted partners, to help with support in dispersed operations. And it's another way for us to shape, in phase 0 shaping, shape the medical laydown, shape the medical environment, and build these relationships. So let's go back to that staff sergeant. What does it look like in a partnered system? Well, one, they have a trauma system. There may be coordination between pre-hospital care and the first hospital where they get stabilized. A relationship and a system to get them to the next level of care. Maybe they have safer blood, more reliable labs, better nursing skills. We have a known quality of care because these are partners we've been working with. working with for, in some places, a couple of years. What does it mean for the DoD? Maybe we don't have to have that large footprint. It'll cost some money, but it doesn't cost as much. We'll get equivalent patient care, but it also means interoperability. It means we can work with this military medical system, both in that host nation, partner nation, but maybe on peacekeeping missions, humanitarian aid, disaster response missions, maybe with large-scale combat. It's a way for soft power for access and developing strategic relationships. And ideally, if the care gets to the higher level, that maybe we have embedded people. Maybe if we have an operational environment where we're doing a lot of work in a country, maybe we have a team that partners. And that can improve our skills, but it has to be the right place, the right time, and it has to be done the right way. Otherwise, it's a waste. So Jordan, we've been engaged with a couple of years. Kingdom of Jordan is about 2/3 the size of Pennsylvania. It's in a geopolitically strategic location in the Middle East. We've been friends with them for quite some time. They have a population of about 11 million, most of them up in the upper western corner by Amman. They have a robust medical system. It's composed of the Royal Medical System, which is the military hospital system. They have Ministry of Health hospitals, private sector hospitals, and interestingly, all EMS is managed by a totally separate ministry, and that's the Civil Defense. While these are all fairly robust entities, they don't really coordinate and work with each other. So back, I'm going to focus here on the King Hussein Medical Center, which is the premier hospital for the Royal Medical Service. It's a big hospital, about 1,400 beds. It's got 6 centers, training activities, both residencies and fellowships, and it's the largest hospital in Jordan. Back in 2018, the Jordanian Armed Forces reached out to CENTCOM and said, hey, we would like to get help with our casualty care. We'd like to get better. So through relationships here at USIS, put together a team, went out and did a trauma systems analysis, helped them with their gap analysis, and found out while they do have good surgical care, they don't really have a trauma system. It's not coordinated. There's no dedicated trauma team. There's no registry of data. There was no process improvement functions looking at trauma. And interestingly, there was no nationally recognized specialty for critical care. There were good trained critical care providers, Western trained, a couple from the UK, but that wasn't a specialty, wasn't a thing. But they were operating in there and running their ICUs. Back in 2019, after forming that gap analysis and helping develop a plan, we had a delegation come here to USIS and Walter Reed, took a look up at University of Maryland and the Maryland trauma system to get an idea of what civilian sector looks like. Then COVID happened. Everything got on hold. COVID didn't hit them the first wave. They managed to miss that. But the second and third waves after their lockdown eased up really caused a lot of problems. There were a lot of people who were having high mortality on the vent. So they reached out. Who did they reach out to? They reached out to their trusted partners. They reached out to the US and their relationship with the UK. So back in the late spring of 2021, we put together a team of critical care folks from Walter Reed, from USIS, as well as from the UK Ministry of Defense, and went out and spent 3 weeks in Amman helping them with their COVID issue. But as you can see, we brought half of them are trauma critical care, the other half are medical critical care. It's because trauma is critical care. We deal with respiratory failure, ARDS, so it was a good fit. What did we do? Well, we spent a lot of time assessing their critical care capability. We were present on rounds, both at King Hussein Medical Center as well as several of the COVID hospitals throughout the region. This includes fixed facilities and temporary tent facilities. We saw how they were doing it. We partnered with them, advising on the rounds. We did not do direct care, but we talked to them about how we were managing patients, how we ran critical care, our multidisciplinary teams, flow of information, decision-making. We also provided critical care academics. While we were there, we also re-engaged with the surgical side, talked about trauma systems, brought up their new goal or additional goal of having a trauma surgery fellowship, in addition to building up their center to a level 1, ACS level 1 trauma center. We also worked on process improvement, spent a good bit of time with their registry, which in the intervening 2 years, they had started to build their own registry, help them with data analytics, how to use that, how to get that data. In this past year, we've had multiple other engagements, both virtual engagements as well as engagements for critical care with the UK team. We partnered with the state partnership program, and that is the Colorado Air National Guard has a long-standing relationship with Jordan. We partnered with them. They partnered with University of Colorado, Denver and Denver Health, and brought out a team of critical care experts, both physician and nursing, to help with the critical care. So while we're partnering with them, we're helping them with their critical care. They're helping us with the critical care portion of the trauma system. MOD in the UK, working with critical care. We engaged with them, had fairly regular updates so that we're all on the same sheet of music. We're all reinforcing each other's work and all working off the same sheet of music with a common messaging. So we're not multiple different people saying multiple different things, because it gets confusing. So what have we accomplished so far? So they've actually started a trauma service. They have carved out of their existing hospital structure a team of physicians and surgeons who are dedicated to trauma. We have a process improvement project. They're doing their own registry, their own data analytics, looking at purchasing an ACS compatible commercial product, but again, money is a problem. They're working with the local chapter of the ACS. They're getting ATLS back online. They've conducted their own multidisciplinary process improvement. What does that mean? That means they got all the different specialties in the same room, talked about a complication, and they didn't start yelling and blaming at each other, which is huge. It's huge to help address those system issues that help these patients. They started trauma fellowship training. They brought in some junior surgeons, and while they're following the outlines that we've provided for them from BAMC and other academic programs here, they're still looking to get more. And they've started their initial process for getting critical care as a specialty recognized in Jordan. So the key takeaways from this: collaboration is critical. There are a lot of people acting in this space, and if we don't collaborate and we don't get on the same plan with the same messaging, or at least deconflict, it gets confusing and frustrating. We've actually talked to the folks in Jordan. They've said, hey, please don't come, because we have 7 other different people coming from other places that want to help. They don't have enough bandwidth. It interrupts their ability to do their job, and it doesn't move the ball forward. Everyone's running in a different direction. It's key to work with the combatant commands. They have this strategic oversight for that area, and it's been incredibly useful to work with. AFCENT, super supportive. They find this is strategically important, and which is why we've been able to get that many missions over these past few years. We've also brought in that National Guard program. Their whole existence is longitudinal engagement with a single country. There are National Guard units that are assigned to countries throughout the world. Incredibly important to partner with them because they can help with that longitudinal aspect. We're working with our UK partners. Again, all synergistic. Other takeaways, we do not drive the change. As much as we want to have Jordan have a trauma system, they have to want it. Because I'm not there right now to point fingers and say, hey, do this, do that. Because I have no power, no control. It's not my house. So they have to have it. And they do. Culture change is hard. We're asking people to change from sort of where we were 20 years ago with a somewhat of a culture of blame and recrimination, especially with process improvement, to one of more equity, openness, and focusing on positive change. That's hard. Trust is important. Trust is really important. It's these relationships that will allow people to show us the complications that they want to hide. If you don't know the complication, you can't figure out why it happened, and therefore you can't fix it. Success takes time. We've been engaged since 2018. We still have a long way to go. They're making progress, but again, it takes time. It doesn't turn around. You don't throw a bucket of money at it and it just changes. Very important, this is not humanitarian medicine. We're not doing this out of the goodness of our hearts. We're doing this because this is geopolitically, strategically important for the combatant command, for the United States government, for the US military. That's a double-edged sword. One, it means we have support from higher levels, but it also means if the geopolitical environment changes and support is not there, we do not have support. Because at the bottom line, it all depends on funding. It all depends on funding. Can't do any of these missions, can't engage without the money, and having that geopolitical strategy and having our mission aligned with that is critically important. So we're way ahead. Well, in Jordan, the National Guard is going in March. They're going to follow up on our milestones. I'm heading in April for another visit, bringing folks from BAMC and Cincinnati Sea Stars, and we're engaged with pursuing longer term funding to try and get some stability. Because all of these trips have been funded with ODACA funds, which means it's year competitive funding every fiscal year. So next fiscal year, I may not be competitive, but longer term funding will allow that follow-up, allow that longitudinal engagement. And at USU, our TC2SE project, we're building that up, working on research grants, collaborating with combatant commands, collaborating with the JTS, combatant command trauma systems, as well as academic partners throughout the country and around the world. I think it's an exciting time, and I'm really excited to be right here doing this. So thank you all very much for your attention. Welcome any comments, questions, or thoughts. Thank you all.